to speak about my research about hemorrhoids and dyssynergic defecation. Everybody, welcome here. And very nice you have you want to follow my presentation. Um, well, I will tell about hemorrhoids and dyssynergic defecation next. I will talk about the prevalence, classification and treatment. Then I will explain something about functional constipation and dyssynergic defecation. I will talk about our prospective cross-sectional study and end with conclusions and take-home messages. Next. Yes. The hemorrhoids are the most common anorectal disorder in Western countries, and most of the people are common with this problem. The prevalence is 44% of the population, and has also a high recurrence rate from 64 till 87. It's more common in whites and in higher socioeconomic population groups, and it results in a reduced quality of life in patients with these complaints. Next. We use always the classification of internal hemorrhoids from Corker still, so a very long time. And we distinguish 4 degrees, first degree from normal appearance and bleeding, but not prolapsing hemorrhoids, still the 4th degree in which the permanent prolapsing hemorrhoids, non-reducible, also not with manual reduction. And in this 4th degree, we include also the thrombosed incarcerated internal hemorrhoids and the circumferential rectal mucosal prolapse. Next. The treatment of these grades of hemorrhoids is in the first place all dietary and lifestyle modification, and after that medication. What's the problem? Oh no.
No, yeah. Nothing. Okay, all okay.
Okay, yes, I can.
Could you please put your mic on mute? Thank you.
Người nước ngoài mà, có anh Tuấn là người Việt.
Yeah, I will follow. Well, medication is also something for people who do not seek health care. There are a lot of people who don't seek health care and go to the shop and will buy some topical to reduce their complaints. But well, a lot of the people who do seek health care, the first option is medication and topical or systemic. And after that, they will refer to the surgeon for bending, sclerotherapy, and well, when it is complicated, grade 4, and also high recurrence, there will be a surgery and till excisional surgery. Next. Well, before we start to explain the results of our study, I will first tell something about functional constipation, dyssynergic defecation, and we use the Rome 4 criteria, in which we know that 25% of the defecations is straining, lumpy or hard stool, sensation of anorectal obstruction or blockage, the use of manual maneuvers to facilitate defecation, and fewer than 3 defecations a week. Well, you need to have 2 of these criteria and has to be during the last 3 months, onset at least 6 months prior to diagnosis. We know a lot of other terminology of the dyssynergic defecation in literature, but now we are a little bit international to talk about the dyssynergic defecation since Baruka et al. At 2006. 31% of the people with functional constipation begin during childhood. And 2/3 of the functional constipation had also, I'm wrong here, has also dyssynergic defecation. Dus there is a 2/3 overlap. Next. The modification from, of the dyssynergic defecation, the Rome 4 criteria, is that there has to be evidence of impaired evacuation based on balloon expulsion or dynamic MRI or other imaging. There has to be less than 20% relaxation of basal resting sphincter pressure and also puborectal muscle during defecation, and it has to be imaged by anorectal manometry or EMG. Or there is also not adequate propulsive forces during attempted defecation. And then we get 4 dyssynergic defecation patterns. Next. We distinguish 4 types of attempted defecation. We have a normal one in which we see that there is a good adequate pushing force, in the same time a very good relaxing of the anal sphincter pressure. And type 1, we see that during the defecation there is a paradoxical contraction of the sphincter. In type 2, we don't see a good pushing force and also paradoxical contraction of the sphincter. In the type 3, we see that the patient can generate an adequate pushing force, but there is there's less than 20% relaxing of the anal sphincter basal pressure. And in type 4, we see that there is no adequate pushing force and there is also no good relaxing. Next. For the defecation, we need a voluntary relaxation of the sphincter, anal sphincter and puborectal muscle. We have to next increasing intra-abdominal pressure. And during this increasing pressure, there has to be an eccentric contraction of the abdominal muscle with a diaphragmatic descent. There has to be also an isometric contractions of the pubococcus, iliococcus, and ischiococcus for the rectal support. I will show you something in a figure. But also we had to have a good urge to defecate. So that means there has to be a good anal and rectal sensitivity and an adequate continence reflex. And this is the image, and this image is made by Delancey in 2007. And here you see the different layers of the pelvic floor. Here is the uterus, the bladder, the pubic bone, and here you see the levator ani, and all these parts of the levator ani muscle gives support to the rectum and is important for a good defecation. this problem when there's no good support, and we see this in the census perineal descent, then is there no good support during defecation. Next. There's also in the anal canal a continence reflex. That's research by Bruns in 2013. And we see here the rectum with the anal canal, and in the anal canal there are receptors located in the superficial, in the subepithelium, and these receptors are important to start a reflex without a direct involvement of the brain. And we call it the spinal anal external sphincter continence reflex, and it is an automatic reflex of the external sphincter. And these receptors are located in the neighborhood of the hemorrhoids. So we have to be aware, because when we had a rubber band ligation in this area, there we see an scarring in this area, and this scarring can also influence this anal continence reflex. Well, next. The complications of functional constipation, dyssynergic defecation, are fecal incontinence. Next. Hemorrhoids, and that's important to know that the odds ratio is 4.1. So you see that the hemorrhoids are a very is a complication of functional constipation, and we see it a lot in combination with functional constipation and dyssynergic defecation. Next. So also the fissuriani, the prolapse. Next. And the fecal impaction and obstruction, which need surgery. Well, I will talk about our research, and the research was the aim of this research was to analyze the association between hemorrhoids and dyssynergic defecation. It was a prospective cross-sectional study, and the number was 63 men and women, normal in the group. The inclusion was the referred patients with symptomatic hemorrhoids grade 1 till 3, and was in a medical hospital in the north of the Netherlands. The exclusion of the patients was there when the blood loss was caused by other diseases or disorders like fissuriani, fistula, proctitis, Crohn's disease, and colitis ulcerosa, and also carcinoma. The people who had rubber band ligation 1 year before are also excluded. The primary outcome was the prevalence of dyssynergic defecation and functional constipation, and we have also analyzed some other things, the relation between surgery in history and soiling. And that's because of the anal rectal continence reflex. We have analyzed also the association between surgery and pain during defecation, association between straining during defecation and pain during defecation, and also the association between dyssynergic defecation and the pain during defecation. Hemorrhoids alone will never give pain. There are other reasons and causes of pain during defecation. Informed consent is normal. We used questionnaires based on their own 4 criteria, and also fecal incontinence and pain. We have assessed the pelvic floor muscle digital assessment using the sleeker list and the terminology of the ICS. We measured by EMG and anal rectal manometry, and we did a proctoscopy. Well, this is the age structure of the study population, and what you see in the left side, the men, and the hemorrhoids are more in the age of 37 till 52. And in women, in the right side, you see 2 periods. The high here in the histogram, you see a lot of women in the period of childbirth, and here you see the higher level in women in the menopause, after menopause. Yeah, well, the patient characteristics are the mean age is 46.5. You see the difference between male and female, the duration of the complaints. It's you see that a lot of people have more than 1 year complaints of hemorrhoids. And the most common complaint is blood loss, and especially during defecation. 80 patients had also earlier surgical treatment for hemorrhoids. Yes, here you see the dyssynergic defecation, and we see in people with hemorrhoids and dyssynergic defecation pattern in 92% of the population. Is very high, especially type 1, in which we have seen that the people had a dyssynergic pattern of the anal sphincter, the paradoxical contraction during defecation. The number of dyssynergic defecation is very high, and we have also made a comparison comparing with normal people in another study, because the dyssynergic defecation in people without complaints is 29 till 59%. And when you compare that, then is it significant? The higher dyssynergic defecation in patients with hemorrhoids. Next. Well, we have also analyzed the functional constipation, and the functional constipation was in 47%. So we see more people with dyssynergic defecation without complaints of functional constipation. A lot of people are not aware of their wrong defecation pattern, and well, it's very strange, but there is a difference between functional constipation and dyssynergic defecation. Next. That was Yeah, next. Yes. Okay, well, these are the associations. And we did a multivariable logistic analysis, and what we saw that there was an association of pain during defecation and gender. It was more common in female. It was also significant in people with previous surgery. So pain during defecation is associated with previous surgery. Association also between pain during defecation and squeezing during defecation. There was no association between soiling and previous surgery. Okay, the conclusion of this is that in patients with hemorrhoids, 91% of the patients have Dyssynergic defecation. And most common is type 1. Only 2% had a normal defecation pattern. It's really less. 33% had dyssynergic defecation, but had no functional constipation based on the wrong 4 criteria. And the most common symptom of functional constipation was strain. After that, a feeling of incomplete emptying and a feeling of obstruction. Next. So the conclusion is also that there is pain during the defecation, significant associated with a history of surgery in case of hemorrhoids, female gender, and straining during defecation. These are the take-home messages, and it's very important. In patients with hemorrhoids, this dyssynergic defecation can be the maintaining factor of the symptomatic hemorrhoids, and we have to be aware of this, especially when we have patients with a recurrency of hemorrhoids. And we have to be aware that pelvic floor physiotherapy could be useful. Pelvic floor physiotherapy is the first line option in functional constipation and dyssynergic defecation, and is based on a lot of research, international. Also, we have to be aware that dyssynergia of the sphincter and the puborectal muscle is more present than thought, especially in proctology. And we have to also be aware that anal sphincter and the puborectal muscle can act different from each other. You see a dyssynergic pattern of the puborectal muscle and no dyssynergic pattern of the sphincter. So in this case, it's very important to use the maple probe, because you can distinguish the cause of the dyssynergic defecation. I can measure with the maple which muscle is responsible for this dyssynergia. And most of the time, I see a lot of puborectal muscle dyssynergia. And that's what is not measured by anal rectal manometry. Most of the time, only the sphincter, except you have very good anal rectal manometry with a lot of electrodes, circumferential and in higher levels, so you can measure the different layers of the pelvic floor. So you have to be aware in which part of the pelvic floor is not good working, has a wrong defecation pattern. Also, you have to be aware that an autonomic part of the external anal sphincter, the external anal sphincter continence reflex, is important in maintaining the high basal pressure and therefore pain. When you have a lot of scarring, or you have a patient with who had rubber band ligation, and after that has serious pain, it could be that some receptors of the anal sphincter continence reflex are affected here, and then you get a continuous working of that sphincter reflex. We call it a wind up, and this reflex is going on and of course maintaining high basal pressure, and the only thing you can do in this is the use of botulinum Botox. Just be aware of this important part of the anal sphincter. I will end with something very important, I think. So here in the Netherlands, we have a good educated pelvic floor physiotherapist. And well, when a patient had recurrent hemorrhoids complaints, send these patients more frequently to the pelvic floor specialized physiotherapists. You can use always a one-time consultation, so you can have the good information of dyssynergic defecation, which can maintain the complaints of the symptomatic hemorrhoids. Next. Thank you for your attention, and I hope I have told you something that you can use in your practice.
Are there any questions? I can see that there is a there's a question.
Can you go to the slides or what's needed for adequate defecation or not?
Yes, I can. Moment. That's
more higher, yeah. Yeah, here.
This one, I guess.
Yeah. There's some, Modinka is asking for to show these slides again. And, oh.
This one, yes.
Yeah. This is important for good defecation. There's the voluntary relaxation, increased intra-abdominal pressure, and an isometric contractions of these muscles. There's a question: how can we know if the external anal sphincter is intact? The anal sphincter reflex is intact. When the bowel is going in the distal part of the anal canal, then this reflex is going on and causes a continence reflex. When some people had in a fast way and very heavy urge to defecate and can't have to run to the toilet, there is this a sign of a not good anal continence reflex, but it's the best way to measure this with anal rectal manometry. When it is in a wind up, you see a continuous high contraction pattern in your EMG, and of course pain, because when this anal rectal continence reflex is going on and in a wind up, it's serious painful. Another question is, how can you measure with the maple or wrong defecation pattern? Well, first of all, when you you can measure the basal pressure of the different layers of your pelvic floor. And is this very high? Then you have and someone has not the opportunity to relax this high basal pressure. Then you have the first type 1 of defecation pattern. But when you ask to squeeze and you see a paradoxical contraction during squeezing, and then you can see, is this the sphincter alone, or is it a puborectal muscle? You see a paradoxical contraction. So this also wrong defecation pattern. So you can the only thing what we can't measure during the maple is the right pushing force. So you have to look how a patient is building up their abdominal pressure, and so then you can see something about the building up of the abdominal pressures. Yeah. At what stage of hemorrhoid we can measure with maple? Any country? In every stage of hemorrhoid we can measure. We measure EMG and no pressure. So the EMG is really important to get good imaging of what the different layers of the pelvic floor are doing. So in every stage it is possible. We see when the basal pressure of the pelvic floor is very high, and you can't do a digital examination without very much pain, then is the measurement maybe also not possible, and we have first of all to relax this basal pressure. When this basal pressure is not the patient is not able to relax this pressure, you have to be aware that some people first have to go for a Botox before we can start with our program. There is no contraindication for the measurement of with maple in which stage of hemorrhoid then. Are there more questions? I think not.
No, not as far as I can see.
Yeah. do some.
Any other questions? I don't think so.
My
Okay.
English is not so very well, but I hope you have heard everything. And well,
Thank you very much.
yes.
Thanks a lot.
Well, I
And-
wish you luck with everything, and also with your measurement with maple and these. The maple measurement in anorectal problems is very important, because we can have the opportunity to get insight of the different layers of the pelvic floor.
Thank you very much, Janneke. Thanks a lot.
Good luck.
This webinar was recorded and will be placed on our YouTube channel. So if you would like to watch it again or share with your colleagues, that's no problem. Thank you very much. Oh, there is one question. How many treatment would you see? The recovery.
Treatment would you see the recovery? Well, recovery, hemorrhoids, some hemorrhoids are only grade 1 or 2, and we see recovery at the moment when when the patient is able to relax the whole pelvic floor and to use the pelvic floor in the right way. When the hemorrhoids are grade 3 or 4, that has to be treated by rubber band ligation or sclerotomy therapy, and after that we have to normalize the use of the pelvic floor, and then we are very important to prevent for recurrency of the hemorrhoids. Well,
Okay.
good luck with
Clear.
everything.
Thank you so much. Bye-bye.
Bye-bye.